I know interventions get a bad rap, you guys. They really do. And I think we're all kind of in agreement that unnecessary interventions are just that. They're unnecessary and we do want to
Sure.
avoid them. But it is just really cool and comforting to know that when we see things going wrong, we have the ability to kind of backtrack a little bit and give ourselves and our baby a little bit of a redo and a little bit extra support when they're asking for it. That's just so comforting to me.
Absolutely. I agree with you. I feel like just because we can doesn't mean we should, but there are lots of things that we do for very specific reasons. And it's really important to make sure that they understand why we're doing them.
Yeah, that's the whole point of this entire show, of my whole platform, of everything, you guys. I just want you to know what's happening so that you can really be the one that is making the decisions. Hello, and welcome back to another episode of the Birth Lounge podcast. You guys, every single week I get to hang out with you, and I'm so excited. Now, before we dive into the episode, I wanted to share an email that I got last week. It was from someone who has been using the Birth Lounge app, and here's what she wrote. Hi, HeHe. Last week, when I went to my 39-week appointment, my doctor really pressured me to put an induction on the calendar, citing that my pregnancy was likely not going to get started without medical intervention. He also said, without following it with any evidence, that he rarely sees moms go into labor these days, and he thinks that it's just the stress level that women are under. Thankfully, through all of the education that you provide within the Birth Lounge app, I knew that I didn't want an induction. So I kindly explained to him that I didn't feel comfortable with that and that I preferred to wait for spontaneous labor. He then proceeded to tell me that he didn't want my placenta to stop working and that he really urged me to get an induction on the calendar. Sitting right there in the office, I pulled up the article about calcification of the placenta and going past your due date, and we had further discussion. He really stuck to his guns about encouraging me to schedule a 39-week induction, and I held strong in my opinion that I wanted to wait for spontaneous labor. I thought I had made myself clear, but when I got to the checkout desk, the front desk lady asked me if I was aware of the orders to put in a 39-week induction and asked me what date I wanted to come in to have my baby. Because of the Birth Lounge app, I was able to confidently decline this even though she continued to pressure me. I used your line that I found in the scripts for advocacy to say that they were welcome to put a date on the calendar, but that I wasn't going to come and I really preferred to wait for spontaneous labor. Although she was a little stunned at my hesitancy to get a 39-week induction on the calendar, she did allow me to leave without making an appointment. I'm so glad I had the data inside the Birth Lounge app to help me feel confident in this decision. Otherwise, I can see how easy it is to be pressured into things that you don't want, and I might not have known otherwise. Oh my gosh, this makes me so happy. I love, love, love hearing you guys take control of the decisions that are made in your pregnancy and birth. I'm so sorry that you kind of had to face all of these roadblocks, or might I say road bumps. They weren't really blocks, but I can definitely hear how your hospital staff or your clinic staff really badgered you into trying to convince you to get a 39-week induction on the calendar. Also, inside the Birth Lounge app, you will find information on induction and C-sections and how those two things are connected. Plus, those scripts for advocacy that you mentioned, not only is that one of our #1 downloads, but it's also one of my favorite tools to keep in your back pocket aka the app in your back pocket, to keep you in control of the decisions that are made and helping you navigate these conversations when they feel a little sticky. You know, if you follow me on Instagram, that I always encourage you to have collaborative discussion, one that is based in respect, but also holding firm to your boundaries if you feel confident in those. The Birth Lounge app is not meant to be your childbirth education. That's what the Birth Lounge membership is for. However, the way that this mama used the Birth Lounge app is absolutely perfection. Pull it up in your OB's office, sitting right there on the exam table to show them the data and the science that back up the choices that you are making. The other way I love to use it, well, there's actually two. When you're sitting in the lobby waiting for your prenatal appointment, go in and find the week gestation that you are currently at. And not only will it tell you what's going on in your body and the development that your baby is at, but also it will tell you the questions about the hottest topics that are on your mind that you can ask your provider to do exactly what I talked about before, having that collaborative discussion. And the second way is when you feel like scrolling social media that, typically kind of gives us anxiety, I recommend that you scroll the Birth Lounge. Instead of scrolling to numb your mind, scroll to empower yourself, scroll to expand your brain power, scroll to get smarter so that you can have a better birth. Download the Birth Lounge app by heading to your respective app store, whether you're Android or iPhone. Type in the Birth Lounge app and download it today. I can't wait to see you there. Bye.
Hey y'all, Alexis from the Birth Lounge team here again today to give you a little intro. Before we get into today's episode, I want to name something I think a lot of you will recognize. If you've ever heard a provider casually say things like ROM, IUPC, or we might need a vacuum, and nod it along while internally thinking, cool, 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 I have no idea what that means, then this episode is for you. And if you haven't heard those things, this episode is to kind of help prepare you for a hospital birth so that if you hear these things, you can really understand what's happening behind the scenes in labor and delivery. And it's not the first time you're hearing some of these terms. Today, HeHe is joined by Dr. Tori O'Daniel, a board-certified OBGYN with over 14 years of experience and more than a decade working as an OBGYN hospitalist. She spends a huge part of her work teaching, training, and leading OB emergency simulations for both nurses and physicians. In other words, she's not just talking about these tools in theory. She uses them, teaches them, and helps train other providers on how to use them safely and appropriately. Together, HeHe and Dr. O'Daniel break down the real tools and procedures used in labor and delivery, the ones that often show up with very little explanation and a lot of urgency. They talk through rupture tests, internal monitors, vacuums, forceps, and newer innovations you may have never heard of, all through an evidence-based, consent-centered lens, as HeHe does. This conversation isn't about making birth feel more medical or more intimidating. It's about replacing the unknown with information. So you're never learning about something for the first time while it's already happening to your body. If you're planning a hospital birth, supporting someone who is, or you simply want to understand what those acronyms actually mean, this episode is grounding, empowering, and incredibly clarifying. Let's get into it.
Dr. O'Daniel, welcome to the show.
Thank you so much. Hello, everybody.
I'm so excited to have you. I feel like, pregnancy and birth and specifically labor and delivery can be a little daunting because, especially as a first time parent, there's so many unknowns. There are so many things where you're like, I don't know when I'm going to go into labor. I don't know what contractions are going to feel like. I don't know who's going to be on call. And one of those unknowns is what kind of procedures and tools will I encounter during my experience in labor and delivery. And so I'm very excited for today's episode because I think it's going to answer a lot of those unknowns, and not whether or not you will encounter them or experience them, but if if you do, you
Sure.
won't be, in the unknown. You won't be questioning like, what is that? How is it used? What is it for? Hopefully, Dr. O'Daniel and I today will be able to give you some good base knowledge that if your doctor says, you know what, we've reached a place where we think we may want to talk about a vacuum, you go, oh, I know what that is, and I know why we're
Right.
using it, and I know what to expect. So
Right.
I'm really excited to kind of dive into all the tools that we may encounter. And I think a good place to start, and for listeners, I'm going to try and go in chronological order of when you might encounter these throughout your labor and delivery process, starting at typically what we kind of think of as the beginning, which we all know that your waters can release at any time during labor. But for some of
Absolutely.
us, they release at the very beginning. Dr. O'Daniel, you guys have a tool, a ROM test, rupture of membranes test, that can
Mhm.
actually confirm whether your membranes have released or not. Tell us about that.
Yeah, so just to be clear, I am an OB hospitalist and I use these products all the time, but we do them in conjunction with clinical evaluation. So if somebody comes in, I work in an OB emergency department, so this is sort of my jam. I am doing this all day, every day. This is what we are taking care of patients doing. And it's not always very clear whether or not your water has broken. And if you read or you hear sort of from your mom, your grandma, your friends, what that feels like when your water breaks. Everybody describes it as this big gush of fluid. And fortunately or unfortunately, it's not always exactly that scenario that happens that it's really obvious. It's beautiful when it is very obvious to all of us. But when you have some leaking and you're just not sure, one of the things that we do is start to do an evaluation to see whether or not your membranes have ruptured. And there's a couple of ways that we can do that. One is this ROM Plus device that you're talking about. So this allows us to take a swab inside the vagina and look to see whether or not your water is broken by collecting that sample and then looking at the proteins. And then we do that with a system where we collect that Q-tip and then we put it in a solution. And it usually results for us in about 20 minutes while we're there in the OBED. And we often do that in conjunction with our exam. So you might often hear or also hear somebody talking about a sterile speculum exam, where they'll put a speculum inside the vagina and they'll collect that fluid as well. And they can look to see if there's pooling inside the vagina of that fluid. They can take that and use a nitrazine, which is a pH tester with a Q-tip to see if it changes color. And then they can also take a collection of that sample, put it on a microscope and look under a micro or put it under a microscope and look to see whether or not there's ferning. And ferning is exactly what you would think of it as the plant. And amniotic fluid, when it's dried over that microscope slide, looks like ferning. And so that in conjunction with this ROM Plus or kind of other clinical findings are ways that we can see and confirm whether or not your water is broken.
That is really cool. Okay, you talked about it being a little confusing. What are some things that might be confusing? This leaking that you're like not sure if you're peeing on yourself or if it's your water. What else might, someone encounter where they're like, I'm not really sure if it's my water or not?
Yeah, this is a fantastic question because I think that it's really unfortunate or fortunate, however you want to perceive this, that there are lots of variations of what happens during pregnancy. And so you have a lot of discharge in pregnancy, and that discharge varies over the course of your pregnancy. And when you get further along in your third trimester, normal discharge can feel very liquidy or sort of watery in context, when you're trying to assess whether or not your water's broken. So just normal physiologic expected discharge can be confusing. Sometimes you can have an infection that also may feel or look like your water. And so that's something else we'll be evaluating for you. If you've had a recent cervical exam where somebody checked your cervix in the office, we use gel or a lubricant to check your cervix. And if there's any leftover of that, it can liquefy because your vagina is warm. And so sometimes that is confusing. And then you can have what we all call the mucus plug. And I hate this term because plug implies that when it comes out, that like right there after everything else comes out, and that couldn't be farther from the truth. And essentially what that is that your cervix is softening up it's dilating, it's preparing and allowing your body to prepare for labor. And so what your cervix was doing really well and holding everything in is softening. So there's a lot more mucus that is coming out from your cervix, because your cervix is supposed to be on overdrive. It's supposed to create mucus when you're pregnant to create a barrier so that you don't have things come up through the vagina and cause infections and things like that. But as that softens, that then comes out. And some people are really clear about, oh, I think my mucus plug came out and I understand what that means. And some people come in and say, I don't know if this is my water. I don't know if my mucus plug came out. Am I going into labor? And it's just confusing because there's a lot of norms that are hard to know whether or not it's normal. And then the last one that you said that is spot on is that your baby is compressing on your bladder. And when the head is falling and engaging into the pelvis, your bladder truly is right on top of your uterus. And sometimes when the baby kicks, or if you laugh or sneeze, urine can come out. And so you're not sure whether or not it was your water or urine. And I've had patients come in and like, I'm sniffing, I'm trying to figure this out, whether or not it's urine or your fluid. So anyway, it's not as easy as one would hope to decide whether or not it's your water.
It's not always as clear as Hollywood would lead us to believe it.
Absolutely. And again, I love hate the internet because it's a ginormous source of information, and social media is fantastic to help educate people as they're going through whatever life process. But it's also harmful in the sense that sometimes it implies something is happening when it absolutely is not. So that's sort of my job. My job is so much about educating and just reassuring people and making sure that they feel comfortable asking questions and knowing what we're doing.
Yeah, I love that. And just giving them evidence-based education to be able to make the decisions that feel good to them. Okay, I do have a question about at the end of pregnancy, one of the
Mhm.
things that's really big on the internet is have sex. Get that
Yep.
oxytocin going. Whether it's true or not, you might find a reel or two that says semen helps, dilate the
Yeah.
cervix. So if someone has recently had sex and there is
Uh-huh.
semen in the vagina when we do this test, does it impact the accuracy of being able to either, could it be mistaken for pooling? Would it impact the ferning, this ROM plus? Is
Yeah.
that a concern?
No, it's a great question. And semen definitely is something that can interfere with some part of your evaluation, because regardless of how you look at it, pooling cannot be as clear cut of just like visually seeing pooling, right? If I see pooling, I typically can assess pretty quickly whether or not it looks like it's coming from the cervix and it's pooling up because it's coming from within. But you're not wrong that semen can interfere in the evaluation because it can affect the pH of your vagina, which is exactly what that nitrazine test is looking at. It does not affect the ROM plus test, which is kind of why when you're doing an evaluation, you want to make sure that you're assessing multiple pieces. I always describe evaluation of patients is often like putting a puzzle together, and you don't always see what the picture looks like until you have all of the pieces of that puzzle together. And so some people come in and it's very obvious because they're grossly ruptured. And what that means in the medical term is like, I can see with my naked eye that you are ruptured. So I call you grossly ruptured because I can see it coming out or it's all over the floor or what have you. But like I said, a lot of times it's not that clear cut. And so I ask all the time, have you recently had intercourse? Have you recently been checked? Has your cervix been checked at the clinic? Has anybody attempted to strip your membranes? Have you used any sort of medication that's gone in your vagina, whether it's been some sort of over the counter yeast medication or if you're using progesterone tablets? So, as a physician, those are things that I'm thinking through about what would be affecting my exam. But back to your original question, absolutely. Knowing whether or not somebody's had intercourse is something that I always ask so I can use that in conjunction with my assessment. And I definitely agree with you that intercourse is something that we recommend to patients who are trying to naturally induce labor, because intercourse, having an orgasm, also having semen inside the vagina can cause things sort of get going to move in the right direction as far as labor.
Nice. We love that. Or maybe we don't. If you're out there thinking like, oh,
Everybody's
heck
different.
no, I don't want anybody in or around me. I totally
Absolutely.
get that. That's so funny. You know, the same thing that gets baby in gets baby out, you guys.
Absolutely. And it is perfectly acceptable, whichever your opinion is as a pregnant patient, whether or not you are up for that or not, you get to have an opinion about that either way. And we have lots of varieties and variations of people's opinions about that.
Totally. And you have a variety of ways of how you can accomplish it. It doesn't have to
Yeah.
be penetrative intercourse, you guys. It could
Right.
be just very sensual touch with your partner. It could be nipple stimulation. It could be
Yep.
self-pleasure with toys. So you don't have to have penetrative sex if that is not on your to-do list. So no pressure there.
Mhm.
Okay, Dr. Daniel, that was so fascinating. So now let's move a little bit into the labor process. So
Okay.
we're laboring. We've got contractions going. We may or may not have Pitocin. And your doctor comes to you and says, I think that I'd like to place an IUPC. Can you
Uh-huh.
explain to us what an IUPC is,
Mhm.
why we would use it, and what its kind of role is? And then tell us why you guys is so kind of special and innovative.
Yeah. So let's start back to the beginning of your question about what is an IUPC, and that acronym stands for intrauterine pressure catheter. And so, just to be clear, when we are monitoring you during labor, we're watching to see whether or not your uterus is contracting on a regular basis. And essentially, there's two ways to evaluate that, either externally or internally. And then in conjunction with that, you can also just do palpitations. So if a nurse or a physician or midwife or bedside, I can feel by touch whether or not your uterus is contracting. But we place monitors on to assess whether or not things are moving in the right direction and also understanding how frequently you're contracting. That external monitor solely helps me understand how frequently you're contracting. So it's an external device that sits on your abdomen, but it's going through layers of tissue, your skin, your subcu tissue, which is that fatty part of the abdomen. It goes in through that peritoneal fluid, so inside the abdomen, and then the uterus. That muscle in the uterus is that uterine wall, and then to that uterine muscle. That tells me how frequently I'm monitoring, but it does not tell me how strong those contractions are. And I think people misinterpret that because when it looks like they're very big, they're like, oh, that looks like it's a huge contraction. And somebody who has a large contraction but isn't feeling anything is confused because they're like, why does that look like it's so big, but I'm not feeling anything? And the difference is that truly is just telling me how frequent you're contracting. The difference between external and internal is that once I place this monitor inside the uterus, then I have a catheter inside there to make sure that I'm not only seeing the frequency of that, I'm actually seeing the intensity of it. And that allows me to calculate whether or not those contractions are adequate. And that doesn't matter so much if everything is moving in the right direction, your cervix is dilating and it's going in the way that we need it to. It matters when things have kind of stalled out. And so if I'm having a contraction pattern that looks like I'm contracting frequently enough, but the patient's cervix hasn't been changing, we kind of have to assess whether or not I might need to give you Pitocin if you're not on Pitocin, or I need to increase the Pitocin a little bit if you're on Pitocin and I'm still not having cervical change. So external monitoring, frequency of contractions, internal monitoring, frequency and intensity of contractions. Now, it's really important to know that if I do internal monitoring, your water has to be broken. I have to be able to have that broken because this sensor is within that. That's the cool thing. You asked about the uniqueness of the sensor. It's within the device itself. And so it has to be able to go into the space that your water is broken. It's sitting in that pocket of amniotic fluid, and it allows me to assess the intensity of the contractions so I can really help tailor to your specific labor process how much medicine I do or don't want to use. And the important thing that your physician, your midwife, your nurse bedside should be talking with you about is that the reason that it matters to me is I really am trying to make sure that we have a safe vaginal delivery. That's the goal, right? And if I can't get you adequately laboring, then we're leading down towards pathways that I would rather not do. I mean, C-section certainly is not the worst case scenario, but I'd rather avoid it if I can. And I'd love for you to have a vaginal delivery if that's what our goal is.
Okay, so I'm so glad that you mentioned the fact that your waters have to be broken. So if we had a need for an IUPC and your waters weren't broken before we placed it, you would need an amniotomy. Is that right? I'm understanding correctly. We would artificially release
Yep.
your membranes.
Absolutely. So I can't use this device without your water being broken. And so if your water is already broken, score works for me. And there are two ways that your water can be broken. It either breaks spontaneously or I need to break it for you. And we can do that by using what I describe as kind of like a little crochet hook, which can be
Yeah.
scary for some people. So I show them this plastic hook. And then when I put my hand inside the vagina, my hand and my fingers are in your cervix. And then I put that hook part against my hand and put it inside the vagina and turn it around when I get to your bag of water. And I just snag that bag of water, turn the hook part back around, and it comes out on my hand. So the hook part really shouldn't be touching the patient or your cervix or the baby. It just goes inside, turn around, grab the bag of water, come back out. And then that will help your water break. Sometimes when we break your water, it's just a little hole from that. Sometimes it just completely separates. So if it's just a little hole, then I'll put my fingers in there and just kind of spread it open a little bit so that your water can come out in a linear fashion.
How far up is that IUPC going, and what does the actual catheter look like? Is it going to be similar to what they put in our urethra for someone who has an epidural?
It is actually much smaller diameter than a bladder catheter.
Okay.
Um, so I think you had two questions. How far does it go up in there? And
Yeah.
then what's the size? So there are two components to this catheter. One is sort of a firmer sheath that goes on the front or more proximal side. So the part that goes up to in through the vagina has a sheath on it to give it some stability because the vagina is a hallway, for lack of better terms, but it collapses on itself because your tissue is supposed to rest against itself. And when you place this, if it goes in there and it meets any resistance and it's super soft, it's going to fold on itself. So that sheath just allows I put one hand inside the vagina and then I place this along my hand and it gives it some stability as it's getting to the cervix. And then once I get it to the cervix and I start advancing it, that I just pop that sheath off because the sheath is not what goes into the uterus at all. And then I can advance this. There are markings on the IUPC that allow us to see how far we're supposed to be advancing it. And it marks and it says pause for flashback, which allows you to have the amniotic fluid fill into that catheter and recognize you're in the right space. And then you can advance it. And then that catheter piece out, the part that's hanging outside of the vagina, can just get taped and then connected to the external device and taped to the patient's leg. And just for clarity, so that people don't completely confuse this catheter, it has that sensor on the end, but it has a little tiny hole at the tip of that catheter that's inside the uterus that allows that fluid to come out and also allows us, if we need to, we can put fluid through this catheter during your labor as well. So in answer to your question, it's much, much smaller in diameter to your bladder catheter. As far as the depth, there are markings on there that show me, and it looks like it's much deeper because part of this depth is your vagina. And so that whole thing is not inside the uterus.
Right. Would you use an IUPC with the external monitoring? Which, guys, when we say external, we're talking about the belly bands, those paddles that we put on your belly, and you kind of wear
Absolutely.
them with those bands.
Mhm.
Are you using both, or once we have an IUPC, we're now done with the belly bands?
That's great. That's a great question. And this just depends on your circumstance. And so you
Okay.
want to make sure you're talking with your midwife or your physicians about what exactly we're changing. And often, although not always, you have another monitor inside as well. So the bands that you have on your belly, those external bands, and or if you have wireless monitoring, some places have wireless monitoring, so you can get up and ambulate, you can actually be in a tub and labor and what have you. Those are all separate because you have to identify contractions with your tachometer, and then you identify the fetal heart tones with that Doppler or that external portion. And if you need more specific or you're having a hard time monitoring that externally, once you place an IUPC, you can also have the option of placing an FSE, which is a fetal scalp electrode. And it's a tiny little wire that goes through the scalp of the baby's head. And that's an internal fetal heart rate monitor. So if I place an IUPC, because I want to see whether or not your contractions are adequate and how frequently they're happening, that does not mean I have to also place a fetal scalp electrode. So you might still have one external band and an intrauterine pressure catheter. Or if I say to you, I need to make sure your uterus is contracting appropriately and adequately, and I'm having a hard time also monitoring your baby, I might place those two things in conjunction with one another, but you don't have to. It's just often kind of that process that you might have both.
I really appreciate how you present that. I think sometimes it can be misrepresented, whether intentionally or unintentionally, as like a sticker or a clip, but it is actually a wire that goes through the skin of your baby's scalp. So I really appreciate how you presented that just very kind of factually to leave it up to people whether they feel comfortable with that or not. Okay, my last question about the IUPC is once it's placed, is it going to remain there through the duration of your labor, or are we getting a read on it and then at some point we will remove it and go back to the belly bands?
Typically, once you place it, it stays there for the remainder of your labor. The only time, and again, this is up to either the physician or midwife's discretion, the only time that we're removing it is typically when you're about to deliver.
For
Sometimes people
pushing.
will, yeah, actually, yeah,
Okay.
absolutely. Like sometimes we will leave it on or leave it in rather while you're pushing so we can still get accurate readings. And sometimes you're making progress so quickly that when I see that baby is descending, I'll go ahead and pull it out right when we're pushing to avoid. Does, you know what I'm saying? Like there are two options. You could leave it in and then it's coming out when the baby's coming out, or I can pull it out because I just don't need, clearly my contractions are adequate if I've gotten to complete and we're pushing. So I usually just typically pull it out when we begin pushing.
Okay, cool.
Yeah.
That is
Yeah.
that's really all like so good to know. I think an IUPC is something that a lot of people who go into labor and delivery probably are not aware of. And then when
Yep.
it does get presented, sometimes it can feel really scary of like, oh my gosh, well now I need these other interventions and like is everything okay with my baby? But understanding why we're using it and that it gives us additional data to help us make decisions, I think is incredibly comforting.
Yeah, and I think that you mentioned something that really is sort of the key to the way that I help take care of patients and that I have perfected and gotten more comfortable talking about with patients is that ultimately this is your choice and this is a collaborative kind of conversation that we're having. And I say, when there are lots of options, we will sit down and have this conversation in a calm way. If there are options that I feel that are critical to your health or your baby, you're going to hear me say different terms and you're going to hear the tone of my voice change because I'm trying to relay to you that this is like time is of the essence. And I love to have these conversations before the craziness of labor happens. And I also don't get the luxury anymore, but I feel like we do it really well as hospitalists. But I think these conversations should be happening in the clinic. So you just said, like, come in and ask some good questions. And those questions can evolve over time through your prenatal period because ultimately this is supposed to be a collaborative decision. And the more that you know, the more you can help me make that decision with you. And the second thing that I mentioned that I don't think we talked about that I do really want to make sure that people are clear about is that the IUPC can be used for that uterine contraction intensity and frequency, but I can put fluid through that device. And sometimes if I come in and I explain to you that I'm seeing some drops in your baby's heart rate that are concerning to me, and I'm concerned that like there's some compression of the cord, the umbilical cord happening, I can put fluid back through this intrauterine pressure catheter to help give just a little bit more buoyancy or fluid around the baby and help see if I can decrease those, what we call variable decels or drops in the heart rate that we know are coming from cord compression. So that was just an aside, but it's really important, and it could be scary if all of a sudden I tell you we're about to put fluid through this thing.
No, I can tell how much you love that consensual care and how much you really do value that collaborative approach with your patients just by
Thank
the
you.
language that you're using. And you guys, today's the first day I've ever met Dr. O'Daniel. So I'm not saying that because I'm like, I'm like secretly trying to get you to love her too. Like, genuinely, I can tell that you really value the relationship that you have with your patient, which I think speaks a lot because as a hospitalist, you're meeting people that day for the first time.
Absolutely.
OBGYNs sometimes encounter that same thing if they haven't had a chance to meet you in the clinic or the
Yep.
office setting.
Mhm.
They sometimes care for people who they've never met before, but you don't even have the opportunity as a hospitalist because you don't do clinic work, right? You're simply at the
Right.
hospital. So I just think that is I think that's really just very admirable. When you talk about putting fluid back into the uterus, is that what we refer to as intrauterine resuscitation?
Yeah, it can be a part of it. So resuscitation is a multitude of things that we can do to help, depending on what we're seeing. When we're doing monitoring, we can see a variety of things on the fetal heart rate tracings. Most institutions have central monitoring. So not only is your nurse that's bedside seeing it, but the physicians that are out on the floor can see it. When we have call rooms, we can see it if I'm in the OB emergency room. And as a hospitalist, our job is to make sure if there are emergencies that we're providing the care for that while their primary OB/GYN is coming in. So we're all watching this. And when your baby looks like it's not tolerating the process, because we think about labor, but we don't talk about the fact that we're essentially squeezing the uterus in labor, which then compresses the placenta and all of that vasculature. And your baby is supposed to be withstanding it, which, often it does really well. But if it's not, there are different ways we can assess that. And this intrauterine resuscitation that you're describing is essentially trying to make the environment that's a little bit hostile right now for your baby better. And I can do that in a multitude of ways. And sometimes giving fluid inside that uterus is one of the ways I can do that.
And the idea is by introducing additional fluid, we make things a little bit more, very medical term, floaty, where the umbilical cord can kind of float about and not have as much compression on it. Is that the idea?
Absolutely. Yep. So if you think of something getting shrink wrapped, they have those
Oh.
fantastic products where you put a vacuum on clothes that you're packing and you suck all the air out of it and it shrinks it. When you release or you break somebody's water, we lose that buoyancy because you're not floating in a pool anymore. And it doesn't mean that babies can't tolerate it. That's sort of the natural process when your water breaks anyway. But if for some reason the cord is sitting somewhere that's compressing when you're having a contraction or just compressing based on fetal movement, then adding a little bit fluid back while your labor is progressing is something that we try to do to give your baby the longevity to tolerate getting through this labor.
Yeah, that is so cool. I know interventions get a bad rap, you guys. They really do. And I think we're all kind of in agreement that unnecessary interventions are just that. They're unnecessary and we do want to
Sure.
avoid them. But it is just really cool and comforting to know that when we see things going wrong, we have the ability to kind of backtrack a little bit and give ourselves and our baby a little bit of a redo and a little bit extra support when they're asking for it. That's just so comforting to me.
Absolutely. I agree with you. I feel like just because we can doesn't mean we should, but there are lots of things that we do for very specific reasons. And it's really important to make sure that they understand why we're doing them.
Yeah, that's the whole point of this entire show, of my whole platform, of everything, you guys. I just want you to know what's happening so that you can really be the one that is making the decisions. Have you heard about the baby soap debacle that happens in the L&D rooms across the US? Well, if you haven't, then let me let you in on a secret. The hospital system often will use something like Johnson & Johnson's baby soap as lubricant in labor. So remember when we were all little girls and we were told not to put soap in our vaginas because it can throw off the pH? And even now as adult women, we're told that we don't need to wash our downstairs lady because she is self-cleaning. She can do it herself. But then in labor, they're going to put Johnson and Johnson's of all soaps in your vagina to what? Help your baby be more slippery, which they don't even need. But I understand if you might want a little extra lubrication down there during the pushing period, and I have a much better option for you. Coconut. And if you haven't heard of Coconut, it is one of my favorite lubes. Coconut's products are made with all organic coconut oil, organic coconut water, and other natural ingredients like organic beeswax, organic cocoa butter, organic sunflower oil, and organic shea butter. Because you know what? What you put in and on your body, specifically for your vagina, the details matter. I love that Coconut uses plant-based, non-GMO ingredients, which are also USDA certified organic whenever possible, and their packaging is plastic-free, and it's made in the US. Coconut offers oil-based and water-based because if you use toys in the bedroom, you shouldn't be using oil-based lubes with those, only water-based. So they wanted to give you both options, but I gotta be honest, my very favorite product that they offer are the singles. These are single packets that you can literally order a box of, put them in your birth bag, and then if you need extra lubrication during labor, you take the box out, use the single packets. You can use one, you can use all of them that come in the box, and I just love it. I think it is such a better option for you to not only give you that extra lubrication if you want it, but you don't actually need it during labor. It helps you have healthier, better sex during pregnancy because obviously we want to make sure that everything you put in and on your body in pregnancy is organic and safe for you and your baby. And it's much better than Johnson & Johnson baby soap, which is going to disrupt the pH of your vagina. Which, who wants a yeast infection in postpartum? Yuck, not me. What an actual nightmare that would be. So head to coconu.com, that's COCONU.com, and use code HeHe to save 15%. Coconu.com, use code HeHe, HeHe, to save 15% and protect the pH of your downstairs kitty. Meow. Okay, so a little bit later in labor, we've labored. We are complete. We are pushing our baby out. Sometimes we reach a place in labor where we need a little extra support in that pushing. This could look like vacuums or forceps, and you guys have the Kiwi vacuum, which I love. I have seen it be used a number of times. And it's quite successful in certain situations. It can really help someone achieve that vaginal delivery and avoid an unwanted C-section in many cases. So,
Absolutely.
tell us about that. Tell us about the Kiwi vacuum, everything that we need to know.
Sure. I think that it's important to understand operative vaginal deliveries as a whole first.
Okay.
And you mentioned forceps and you also mentioned vacuums. So I use both forceps and vacuums, although a lot of physicians no longer use forceps and or just weren't trained. And that really is unfortunate trend over the last decade or so, maybe even 15 years, because a lot of OBGYN residents are just not trained and some are. So it's fantastic if you have both options, but you want to ask your physician if needed in an operative vaginal delivery, what would be the mode of device that you would consider using. And the first thing that we attempt, or most of us attempt, is we are trying to realign your baby's head. And so we have kind of an early attempt or intervention is we're trying to move your baby or rotate, you might hear us calling rotation, with our hand. Just to back up even further, to understand how your baby is coming out of the vagina, is that there are something called the cardinal movements of labor, where your baby's head, it's so stinking amazing. I still don't even know how this, like, to talk about this is really impressive, to even think about the fact that this is what our bodies do. But your baby is trying to get into your pelvis with the smallest diameter coming through, which is fan-freaking-tastic for your vagina. And also works out really well because it doesn't require as hard of pushing to get the smallest thing out. So you can think of this in any way that you want to, that when something is coming out of a hole, you want it to have the smallest diameter, the easiest way to get it out. That's what your baby is internally trying to do. It automatically is trying to get this rotation as it rotates. And that is what we call the occiput. And there are soft spots on the baby's head. So your posterior soft spot is called your fontanelle, posterior fontanelle, and your anterior soft spot is called your anterior fontanelle. And we can assess when we're putting our hand in there which position your baby is in. And then we also assess how dilated your cervix is, how thin your cervix is, and where in your pelvis your baby is. We call that station. So cervical dilation, effacement is how thin your cervix is, and then station is how deep in the pelvis it is. So when your baby's coming down, if it's not coming down the way that it's supposed to, and or if you've gotten to complete and you're pushing and I'm not seeing a whole lot of descent or movement into the pelvis, I may assess which way your baby's coming down. And we often describe a term called sunny side up. And if you're in the wrong position and that posterior soft spot is at the back of your pelvis, so I'm staring up at the sky, that's called OP. And the way that those cardinal movements work beautifully is when I get this tucked in position and I can come through the pelvis underneath that pubic bone and come out and then flex out, right? If I flex in, it's the smallest diameter coming through the pelvis. And if I'm sitting here staring sunny side up, my chin is in the way and it's hitting that pubic symphysis. And people can deliver babies that way. It happens all the time, except for it's harder to deliver that way typically because it's a larger diameter coming through the vagina. It requires more maternal effort to get that baby to come through. So we're trying to get the cardinal movements of labor to reinstitute and get the smallest diameter coming through the pelvis. So forceps are ways that we can use what we call blades, and they look like salad tongs for better lack of better descriptors. And they go around the baby's head, and sometimes they can rotate, and then they allow us to pull while the mom is pushing to get the baby to come through. A vacuum uses a different approach because it puts a little suction cup right on the baby's head and allows the baby to come out with our effort and the maternal effort. A thing that a lot of people, and I would gather to say that not only patients are learning this, but as we teach, because I train how to use this device, that physicians often are learning how this works, is that a vacuum is not only I'm providing external effort for you, but it's a rotational device. And if I put this cup essentially 2 to 3 centimeters in front of that posterior fontanelle, so I'm on this point that when you think about physics actually helps this baby start to reinstitute those cardinal movements of labor and rotate while you're pulling down. It's not only giving additional effort with the mom pushing, but it's rotating to get the smallest diameter of the baby through the pelvis. I was shook when I completely understood this, because when I trained, I didn't really understand that whole phenomenon. I just thought we were putting a vacuum on a baby and giving effort because the maternal effort wasn't as good as it needed to be. But it's really the combination of reinstituting that cardinal movement of labor rotation to get the baby to come down with the least amount of effort, that in conjunction, the patient is giving me pushing and I'm applying the vacuum and then creating traction. So this can be a really scary thing. And I think that for good or bad, or however you want to think about it, patients are afraid because, like you said, they don't want intervention. They want this to just have gone like they anticipated that their birthing plan was going to work out for them. But when used in the right setting, this is a fantastic way to have a successful delivery. And as long as I've had a conversation with you about what that looks like, I think it's something that I have become really comfortable having a conversation about, and also training and teaching that we can do it appropriately. So one of the things I really need you to do is push with me while I'm using it. And oftentimes in that state of you are exhausted, I've had patients ask me, can you please just do this for me and pull this baby out? And that's not really what this is. This is a joint effort. We are playing together in this process, and I really need you to help me. So you will keep pushing while I'm using these devices.
Does someone need to be on their back for this, or is this a device that we can use in maybe like a squatted position or even hands and knees as long as your provider has good access to your kind of pelvic region?
That's a fantastic question. And ironically, I've never had that asked ever. And I've been teaching this for years. But
Yeah.
I would say that best case scenario when using a vacuum would be on your back. And the reason I say that is because when we're pulling as you're pushing, I really am following what we call the curve of Caris. And that's the curve, the natural curve of your pelvis to be able to get the baby to follow this rotational maneuver. And to be able to do that safely as your physician, I need to make sure that the direction in which I'm pulling is in fact the correct direction. And to do that, being on your back would be the most ideal scenario.
Yeah, I would be interested to see how it would work on hands and knees because we still have that curvature, right? You would be pulling
You'd have
probably
to be
more
pulling up.
towards, yeah, more towards like their knees, right? Because,
No, no, because if you're on your back, I'm pulling down because I'm allowing the baby to rotate and then come down. And then the baby will continue to rotate down and then up and out after it gets
mm,
out. If you're on hands and knees, now the curvature is that I'm pulling up because I'm trying to get the baby to come down through the canal with the
under
curve
that
of the
pubic
legs.
bone.
Yeah.
Got it.
Yeah.
Right. Hmm. So interesting. Okay, I would love to talk about the three pop-offs. So is that still kind of the general rule of thumb that if the vacuum, because the vacuum, once it's attached, it is not like the FSC where it screws into your baby's head. It is a suction cup.
Right.
If it becomes unattached, what I have learned just as a doula of kind of witnessing it and being in births where it's used is that if it pops off 3 times, then we would need to talk about other options. Is that kind of the general rule of thumb?
It's funny that you asked that because that's kind of a misnomer amongst
Okay.
physicians about the rules of the rule of threes for 30 minutes, 3 pop-offs, and 3 pulls.
Oh,
Um, and specifically with the Kiwi device, if you look at the IFU on the device, which is the indications for use, their limit is 2 pop-offs. And that's because Atlo Vaca, who's an OBGYN who has since passed away, but created this device, did a lot of studies, trained a lot of residents in this device, and talked about what some of the safety features are. And we teach essentially 15 to 20 minutes for the length of the procedure, 3 to 4 pulls. The baby should be either at the perineum, which is right at your labia, or coming out, and 2 pop-offs. And the reason for that is because pop-offs are not a safety mechanism of this device. So the way that you described it is exactly right. I'm putting this cup on the baby's head and I'm creating a suction so that as I'm pulling, it has that suction attached. And if it detaches, it is increasing the risks of injury or complications. It doesn't mean that if I have a pop off, an injury has occurred, but it does mean that I'm increasing the risk of that. Because if you've seen, as a doula, you've seen a pop off, it's pretty obvious that the pop off has occurred. You can hear it. Sometimes you can see it sort of recoil back. That's not a safety mechanism of the device. And the intent is not to pull until pop off.
hmm.
So we teach 15 to 20 minutes for the length of your procedure, um, 3 to 4 pulls, either at labia or delivered, and or plus or minus, the 2 pop-offs. And we use that as recommendations. Those are not black and white, hard and fast rules, but it's recommendations to say, if you're attempting a vaginal delivery with a device, i.e., a vacuum, you want to do this in a way that makes sense to be as safe as possible. And if those things haven't been met, or you've had 2 pop-offs and it's been greater than 25 minutes or what have you, then you're assessing kind of what the next steps are. It doesn't mean that if you have a baby that has gotten all the way to the labia and the head literally is sitting right there, and I've had 2 pop-offs, I might make that clinical decision and say to you, I would like to try this one more time. to see if I can deliver, because the difference between attempting that one more time versus essentially having to push your baby up back into your pelvis and then do a C-section, again, I'm having a conversation with you about the risks for that. And one of the things that I try to explain to people all the time is that having a baby, although very natural, still comes with risks in and of itself, plus or minus anything that we do. And I want you to know that I know what the limits are. I know what the recommendations are, but I also know that pushing your baby back up versus attempting one more time when I think we can do this vaginally is something I would gauge with you what those risks are. So those risks or recommendations are guidelines, and the physician has to really make that decision in a very high stress, high critical time to be able to make that assessment for helping you decide in that moment what risks are greater than others.
Yeah, I mean, that just goes back to that collaborative consensual care, right?
Yeah.
Here are the
Mhm.
risks, here are the benefits, here's
Yep.
where I'm at clinically. How does
Yep.
all of this feel to you? And how do you feel about taking on these risks versus
Yes.
having a conversation about something different? So that something different, you kind of described it. Would it be to just then do a C-section if we're unsuccessful with a vacuum? That would be kind of our last option.
Yep. Because if you look at what your options are, is a device and or a C-section. And it's not recommended that you use one device after another. So if you've used a vacuum and it didn't work, you should not be switching to forceps and vice versa.
Wow. Okay.
There occasionally are circumstances that people have chosen to do that after evaluating the risks, but that's rare that we would do
Okay.
that. So really, if it's not worked, you should be assessing why it didn't work, and you should be prepared to do a C-section. But absolutely, some people will have counseled about these devices, and because they understand the risks and they have a preference, they'll say, I don't want to attempt an operative vaginal delivery. I want to do a C-section. And as long as we're all on the same page about what those risks are, that's perfectly within your right to do so.
Yeah, I've seen the same thing where people just are more comfortable choosing a cesarean birth over even attempting a vacuum assisted vaginal delivery. And I agree with you. If as long as everyone feels good and confident in that decision, then that's how we should proceed. So, how do babies typically tolerate the vacuum? Should we be expecting some funky fetal heart tones or any sort of, I guess, disruptions to our fetal heart tones when using the vacuum? Or do they typically tolerate it pretty well?
Yeah, no, your fetal heart tones are not something that should look really any different with your
Okay.
delivery, regardless of mode of delivery, whether it's a forcep or a vacuum device or without assistance. I should still be getting appropriate oxygenation, which should be showing on my fetal tracing. The thing that just sort of a segue into what you should expect is that you have what we call a chignon, which is a fancy way to say a hickey on the baby's head,
Oh,
because you are creating a vacuum. And so I often will show patients, because I have one that just is not for use, that I put on my hand and show them like it creates that suction. And it is really like a hickey, but we call it a chignon, which is, I don't know why we don't just call it a hickey.
oh,
That's
chignon.
because it pulls the fluid into that space where the cup was. And so it's going to take a little bit of time for that to go away, but it looks a little cone headish. Your baby's already molded. That's why your baby's soft spots exist, so that those the skull plates can move and align. And then when you come out, so I would say it's going to have a hickey for a couple hours to a couple of days, because that takes some time to go away. And I always state that very clearly so people don't freak out when we deliver and then they notice that on the baby's head. So that's a normal expectation. But as far as fetal heart tones, I should be able to continue tracing, and I should not expect any different tracing when I'm using a device.
That's good to know. Okay, my final question is not really about the kiwi itself, but why do you think physicians are no longer being taught about forceps? Why do you think we're kind of losing that skill, or I guess that it's kind of being chosen to not be
Yeah.
taught?
I think if you ask 5 different obstetricians about this, you're going to get 10 different answers.
Okay.
But if you're looking at sort of in totality, why I think that that's the case, I think because there has unfortunately been some alignment of forceps and legality issues. So the use of forceps have more of a litigious environment for people to be sued, and they're uncomfortable with that. And then also we've changed the way that we use forceps in the sense that we used to use forceps when a baby was at a much higher station than we tend to do now. And because we stopped using that and we're using it now when they're more engaged, those physicians that were trained really well in forceps started sort of retiring out. And if they didn't continue to train, then you have this lost art because people aren't being trained because there's no longer anybody to train you. So as time moved on, that evolved. And then you had the vacuum, which was created after the forceps. And so people started using the vacuum instead of concomitantly using or being trained both devices, then they just learned how to use the vacuum and then unfortunately lost the art of forceps. And this is really globally dependent on what region you're in because we teach globally, and some places tend to use forceps more than vacuum. Canada tends to be, at least my experience, more forceps than vacuum, and places in Europe, same kind of thing. And I actually had to ask to be trained in forceps. And so I had some attendings that were old school or the OGs that taught me, but I was very like purposeful in asking to be trained in both. And yeah, so again, I feel like it's an evolution for a number of reasons. But ironically, there are still some institutions in the United States that are very adamant about teaching forceps. And some of them, a few of them, not many, will only teach forceps and not teach vacuum. And I feel like that's too much.
On the opposite end of the spectrum.
Yeah, what is that? The pendulum. It's like too far
Yeah.
from me. I want you to hover in the middle so that you have both options, so that when you're offering options to your patients, that you have more at your disposal. And I'm a huge proponent of, I want my tool belt to be full of tools. I want to know how to use all of the things so that I can see what a patient presents me and then pick which thing works best for me to be able to help them get some sort of success.
Absolutely. You can never have too many tools in your toolbox, but there are several instances where we go to grab a tool and say, gosh, I wish I had a skill for this, or I wish I had
Yes.
a tool for this. So I completely agree. Okay. So we have, keeping on chronological order, we have tried the vacuum, and
Yeah.
unfortunately it didn't work. So
Right.
now let's talk about your tools for C-section. You guys have this really neat, what we call the Traxi
Yeah.
tool for someone who is birthing in a larger body. Tell us
Yep.
about that.
Yeah, absolutely. So, one of the things we want to make sure is that we're having a very informed conversation about kind of your particular desires, whether that's C-section or vaginal delivery. And then if you are getting a C-section, regardless of that was your goal, right? You're having a scheduled C-section versus sort of your labor got us to a C-section. We want to do that in a very safe environment. And those living in larger bodies have some obstacles for us as obstetricians and surgeons to make sure that you're doing that safely. And one of the ways that happens is that if your belly, and the medical term for this is pannus, and we have lots of terms as patients and physicians about what we call this. So I just sort of take the guide of whatever my patient is using, and that's kind of how we refer to it. But if your belly hangs over, where I would typically make that incision to get into your skin, to get down to your uterus, then I need better access. I need to be able to visualize because you want me to be able to see that. And you want me to do this in a way that still provides you your dignity. Having a conversation about patients who are living in larger bodies does not need to be an uncomfortable conversation as long as we're being super candid and honest about, I don't have any judgment about this. I just want you to understand why I'm doing these things to be able to make sure I'm keeping you safe and in a really dignified way. And so the Traxi truly lets me do this because it is a sticker device that allows me to use in a sterile condition to lift that pannus or the excess tissue up so I can see and access the space that I need to be able to safely do your surgery and then also get your baby out.
So before the invention of the Traxi, what were we using?
It was a combination of things. And in medicine, we are often, well, historically, we've often been used to or accustomed to trying to make things work to keep people safe in ways that we didn't necessarily have the tools to do it. And so there was a number of ways, one of which can be assistance. So if you have people who are in the OR with you and can help lift that belly up while you're doing the procedure, that's one way we attempted to do that. And unfortunately, that is filled with some frustrations because the surgeon needs space. And if you're adding an additional person there, that impacts the way that I can access the surgery that I'm performing. And also, that increases the risk of injury to that person helping lift that belly up. And so that's not ideal. The other way that we have done this is we've used tape to tape on the belly and then lift the belly up with tape. But that requires the tape to go up past the patient's shoulders, that we would
Wow.
do this prior to prepping or making their belly or abdomen sterile with a sterile solution. And then that would have to hold back near their shoulders where they're sitting or their head is sitting with the anesthesiologist that's there. That is sort of filled with complications in the sense that's not very dignified way to do this. Patients often feel embarrassed or just vulnerable when they recognize that that's having to happen. And also, it's not the best way to use this device because there's tape back there and that tape can slip or move. And it requires adjusting in the middle of the operation. And so, those are not ideal scenarios for that procedure. You want to be able to lift the abdomen, have access to your care in a dignified, clean, sterile environment to be able to do that.
Yeah, I can imagine the complications that came with those other two. And I gotta just put in a little side note here, you guys. We recently hung shelves in our home, and I obviously was the one that was holding them as my husband was drilling into our walls. And the pressure that I felt to just hold up a shelf, I could
Uh-huh.
not imagine being the person that was responsible for holding up someone's body part while a surgeon was operating on them. I just feel like the mental pressure of that would be way too much for a
Yeah.
perfectionist like me. And so I really love the Traxi. I got a chance to kind of play around with it physically at a conference that I attended this summer. I've told you guys about it. It's the A1 conference for neonatal and OB nurses, and NICU nurses and all of our nurses. But it's a very cool device. So I have two questions about it. My first question is, how long does it stay on? Or are we taking it off as soon as the surgery is complete?
That's a good question, but it really varies on physician preference. So you can keep it on post-operatively up for 24 hours and leave your
Okay.
belly lifted up. We don't do that in my facility for a couple of reasons. One, is that we place this sterilely. And so we have prepped the abdomen and then place this device sterilely on the prepped abdomen. So when I say prepped, I'm cleaning your belly off with that solution, and then I'm placing the Traxi on it sterilely, and then I'm putting your drape on. When we finish the case, then I'm pulling this off because we are going to wash off your abdomen, and that Traxi is on top of that prep. So we don't want to leave it on for 24 hours. You can prep over it, which means placing it non-sterilely. I can lift the abdomen up and place it on your belly and then prep over that. And so if I'm washing that off afterward, perfectly fine and acceptable. And so I think that really just depends on physician preference and also workflow, and kind of the way that it works in your hospital. But if you're asking logistically, like, what should I expect? You can ask to see what happens or what's the typical workflow in that hospital, or just ask your doc what their preference is. So it's either going to come off right after, so you wouldn't even know that it's on because it comes off with the drape, or you could expect that it's still going to stay on and then they'll take it off in the next couple of hours and or the next day when they're rounding.
Yeah. Okay. And then my next question is for someone who has allergy to adhesives, are there any additional conversations that those people need to be having with their provider around the adhesive that is used with the Traxi?
Yeah, that's a good question. And I think that the difference for me would be that if I was a physician that left it on typically for 24 hours, I wouldn't. I would choose to not, so that I'm giving the least amount of exposure. And these types of medical grade devices typically are hypoallergenic. So they have a lot of low chance of causing irritation for those who have sensitivities to adhesives and things like that. But I would be really mindful if I was one of those that use it for the 24-hour length, that I would probably just use it during the case and then remove, just to kind of help decrease that chance. And
Yeah.
so if you're one of those patients that have that issue, absolutely say something.
Yeah, for sure. And I mean, you even have the right to request, if you ask your doctor about it and they say, "Yeah, we typically leave it for 24 hours." You have the right to say, "Is there any way that we could not leave it on me for 24
Uh-huh.
hours?" You guys, if you have questions about this and you find that your hospital doesn't have the Traxi, don't be afraid to put a little bug in their ear and say like, "Hey, if you've not heard about the Traxi, please listen to this episode of the Birth Launch podcast," because I think it would be something that I know I, as a consumer, would really love, and your other consumers who might be living in a larger body would really love, and it could be something good for you guys to get. And don't worry if you're a provider out there that's listening, being like, "Well, I wanted in my hospital." We're going to tell you at the end of the episode how you can connect
Yeah.
with Tori and the Laborie team about how to get it in your hospital. Okay, so Dr. O'Daniel, after we are done with surgery, we've
Yes.
removed the Traxi.
Yes.
Now my brain goes to healing, and that we really would like to keep that pannus away from the incision site to promote proper healing. You
Mhm.
guys also have almost an extension of the Traxi that will help with this. Tell us about the Abby.
Yeah. So, as physicians, our goal is to try to make sure if you're having a surgery that you are in a path to make sure you're healing in the best environment. And so we have something called ERAC or ERAS, which is a medical term for essentially enhanced recovery after either a surgery or specifically after a C-section. So ERAC or ERAS. And we do that by making sure that we're trying to get you preoperatively in the best mode of care prior to your surgery. And then we have very specific things that we're attempting to do while you're in the hospital for your recovery. And that's inclusive of making sure you're up walking and taking appropriate amounts of medications that may not be all just strictly narcotics and things like that. And one of the things that we try to do is give you the best environment for healing. So I just told you that Traxi is allowing me to have the best access to making sure that I'm making this incision where I need to make it for you and to get your baby out safely. And why not carry that on to making that same kind of environment that I'm giving your body the best access to healing? Because your body wants to do this well on its own. So there's a number of products that we can use to see how we make that environment better, like a device or a bandage over that incision. There are things called wound vacs that people sometimes will put on there to kind of help create a different environment. And the Abby is doing something that I love because I can use it in conjunction with any of those other products. So, a lot of my patients that have what we call that redundant tissue or that pannus that hangs over, if that's hanging over where I made that incision, then I would love for it to be up and away from that incision to allow the incision to get air. It needs air to heal. That's what our body does. And if it's closed or pushed over it, it creates this sort of anaerobic environment, which essentially means like I'm starving it of oxygen because it's compressing it. And when it's compressing it and I don't have a lot of airflow to it, then it allows bacteria to sort of grow and culture in that space. And patients often don't completely understand that, but what they do understand is that when somebody moves their belly or if they move their belly, they notice this odor and they're like, what is that smell? And then they get embarrassed because they feel really vulnerable about, I don't want to smell. And your hormones are kind of all over the place because your placenta just left your body and you're feeling stressed anyway. And then you're like, what is happening? So we want to help provide that area with air. And using an Abby is very similar to a Traxi. It's a slightly different material. It's not a sterile device, but it's kind of what I describe as like a window cling for your belly because you can peel it and put it back on. It's reusable. You can use it off and on for 14 days. And I put it on post-operatively. And then as I place it, I also then pull your belly up and lay the top part of it down. So it lays on your belly right above your incision, and then it pulls your belly up away from your incision and then lays down on the top right underneath your breast, like near your diaphragm there. And it lifts and then compresses. So it kind of causes that sort of compression feeling. So you feel a little good pressure whenever we talk to you postoperatively and you feel like, oh my goodness, I feel like my guts are going to come out. We always talk about compression using a stuffed animal, a pillow, anything to kind of hold your belly when you're laughing or coughing or whatever, because you feel like everything's going to come out. This gives you that same kind of compression, but it lifts your belly up off of that incision and it provides that compression. We use something called an abdominal binder a lot. So people will see a binder and that's the same thing. It's kind of like a makeshift girdle, right? So you're causing compression to feel that extra support. And those are fantastic. I use them sometimes too. But what it doesn't do is lift your belly off of your incision. So it compresses you, which feels fantastic, but it compresses the belly into the incision. And or if it adjusts or moves when you're laying down, the bottom edge of that hits right in your incision and it hurts. I've had a C-section. I know what it feels like. It does not feel fantastic. So the Abby lifts that belly up and then causes some compression to help with that discomfort. And sometimes my patients will say, I still need a little bit more compression. And I'll just put a binder on top of the Abby sitting there. So it's already lifted it up away and then causes compression more that they need. The reason that I've really chosen to use this for my patients, that I love it, is there's a number of reasons, but this gives the ability of the patient to place it and adjust it themselves. So you get that autonomy that you need. It's reusable, it's hypoallergenic and hydrophobic, which means that when it gets wet, it loses some of that sticky material or that sort of sensation. So you can wear it in the shower, but a lot of people tend to end up not wearing it in the shower in my experience because it starts to peel away. So I just have them lay it on the counter in the bathroom. And then when they get out, if it got a little wet, you can just pat it dry and it gets retains its tactile or stickiness. You can do it yourself. You can adjust it yourself. So when that swelling of your belly and things in your uterus goes back down to its normal size, you can adjust that. And if it gets dirty, because things are happening when you're when you're breastfeeding and having an incision and all that, you can just wash it off with warm soapy water. And then exactly what you said about if you have sensitive skin, this is hypoallergenic, so it shouldn't be causing any increase of that kind of sensitivity that you were describing.
I love that so much. I know that for so many people, providers and patients, it's really on our mind about infection rates when it comes to C-sections, right? It is just part of the
Yeah,
process. But we want to do what we can to reduce
yeah,
infection rate all the way around from the actual operation itself to the
yep.
healing postpartum. And
Mhm.
so I learned about the Abbey this year at the A1 conference, and I was just completely blown away. And I was like, oh my gosh, I have to get this out to my audience. Like I have to get this to my community because it is such a cool device. And I
It
love
is.
that you can go home with it. I love that it is sent home with you and
Yep.
you're empowered to kind of facilitate that healing in your own body as well.
Yeah, and the material is really soft. It's super
Yeah.
soft and not like scratchy. So when you wear your clothes over it, it doesn't tend to bother people. And the other thing that I love is that Laborie listened, because when they first distributed it, it was sort of a tan color, and feedback was that, hey, I feel like this is not sensitive to all skin types. And so they listened and they changed. It's now sort of that green color that goes with the Laborie colors. And so it's relative and diverse for all skin types, which I just love. I love when companies listen to not only physicians using the device, but listen to patients when they say, this is great, but this could be improved. So that was a nice change that they changed recently to that green color.
Okay, me too, because one of the things that I hold as such a priority in this community is really seeking out companies that are honest and transparent and truly driven by consumer relationships. I want to make sure that who I platform actually does care about improving maternal health. And that was one of the things that drew me to Laborie when I first learned about them a couple of years ago is they were eager to get my response and my feedback as a doula. They were eager to show me their products and say, what would you change, even as a
Sure.
non-medical personnel? Like, what do you think would make this a better experience for moms and for people going through these experiences? And that has just really stuck with me. So I'm not surprised that they listened. It just like really warms my heart. And I think it really does go to show that they genuinely care about improving our outcomes in our country, which is just so heartwarming. Okay, my last question, and Dr. Daniel, this has been so good. I feel like people are going to walk away feeling so much more knowledgeable about the things that they might encounter in labor and delivery. But I'm
Okay.
ready to make a tiny shift to the NICU. So
Yeah.
let's say that we have a NICU baby and they are needing to have an IV place. I think one thing that can be very startling and really unexpected is that a lot of times in our NICU babies, IVs are actually placed through their umbilicus, which is your umbilical cord, right? So
Yep.
where your belly button is, you guys, and it can sometimes be off-putting. We always think about putting IVs in our arms or even in our hands, but with tiny babies, that's not always possible because their little veins are just that. They're so little that we sometimes need a larger vein, which is going to be located in their belly button. You guys have one of the coolest devices. It's called the Life Bubble, and it is basically a little plastic, I want to say cage, but I'm really kind of blanking on a better term, and it goes over their belly button and prevents this IV from being pulled out, or NICU babies love to pull out their own lines for all sorts of things, and so it prevents them from pulling it out. Tell us about the life bubble.
Yes, that's a fantastic way of putting it. I would describe this as a clear mobile helmet for the
Yeah, a
IV.
helmet, much better than
Yeah.
a cage.
It's okay. So it sits over, yeah, a couple of things. Let's back up one thing. So your umbilical cord has been your lifeline for your entire existence in your mom's uterus. And when it comes out, it still is working and patent or open for that matter. And so neonatologists are brilliant and recognize that this was a really easy, accessible way to provide medication, fluid, blood, what have you. And so they access that really quickly. And the thing that's scary, or the thing that you think of, is like, if you have a baby that you don't anticipate them going to the NICU, by the time if they do have to go to the NICU, it's a very scary thing because there are lots of new things happening to you. So understanding how they're accessing some of these sites is really important. When you place a line inside the umbilicus, it can move because of its location in general. And it's what we call a central line. You have access into the baby very easily in this port. And you don't want two things. You don't want it to be exposed to infection, and you don't want it to be mobile. You don't want it to move or migrate, as they say. So, again, because we in the medical field are all MacGyvers at heart, we tried, or they tried rather, that's not my field, but they tried to create these types of systems with tape and things like that to keep it up off of the abdomen and also secure so that it doesn't migrate, and that patients are able to hold babies because they're trying to have skin to skin and bond with babies that are in the NICU. And so this device allows that securement in a nice, safe, clean way to help prevent migration so that it stays patent for as long as they intend to use it, and allow access to the baby in these critical moments in a way that decreases the need for having to sort of retape and stuff like that. It's just this nice little clear mobile helmet that I would say that secures the line and then also allows a patient and a family member or whoever to hold the baby and not have all the nursing team kind of sitting on their edge of their seat waiting for that to misalign that. So it is a fantastic device. I think it approaches appropriate patient care as far as like recognizing the infant is not just one piece, but that there are components of how a baby grows well in the NICU. And one of that is that bonding that you have with your parent or loved one, and doing it in a safe way. So it's pretty fantastic device.
It really is. I mean, you guys, my jaw fell open all the way to the floor, and I was like, this is one of the coolest
Mhm.
inventions I have ever seen in
Mhm.
my life. And it's so innovative. And I do love that it prioritizes skin to skin, just another reason or piece of proof that Laborie genuinely does want to facilitate
Yep.
what is best for moms and babies and families and bonding and improving our outcomes. Like you can just see that is a common theme throughout everything that they do. And I think that's why I'm so drawn to them as a company. And so, yeah, this was awesome. Oh my gosh, Dr. O'Daniel, this was just so good. I feel like there's so much fear around encountering interventions in our labor and delivery experience. And I think we did a good job today of outlining when they're appropriate, how the specific tools can actually improve your outcome, can make
Yep.
things better, can give us additional data to help us make more accurate decisions going forward in your birth experience. So thank you so much for being
You're
here.
welcome. It's my pleasure. I love being able to help educate, but I educate not only on the physician side, but the patient side, I think is so crucial to make sure that everybody is on the same page because that's how you get to make, collaborative decisions.
Oh my gosh. All right. We need to figure out a way to clone you and get you into every L&D
I
room.
don't know about that. I don't know that my husband would agree that cloning me is going to make things easier for him.
Oh my goodness. All right, you guys. I hope that y'all loved today's conversation. And if you heard anything, either as a patient or a provider, and you're thinking, I want to get this into my hospital, Dr. Dino, how can someone do that? Where would they connect the Laborie team to be able to inquire about maybe getting this into their hospital if it's not already?
Yeah, absolutely. So you can go to their website and get into sort of their portfolio and see what kind of devices that they have, which gives a nice little synopsis of what they have and what they do and that kind of stuff. And then you can also contact or ask and request to have contact with your local rep. So your representative is the one that's going to be coming to the hospitals and giving you information about that device itself. And then the other component of Laborie that's pretty stinking fantastic is that there's a huge education department that is what I consult mostly with. And we educate those physicians and midwives, whomever that are using this device, and also the nursing staff to understand so that the team in the hospital is really well informed and anybody can access and request this kind of information. The rep will get you started, then a clinical education specialist can be involved in that education component. And as a patient, you can go through and then you can make a little list and just ask your physician, hey, can you tell me about whether or not you use this and whether or not you would consider using this? So that would be my advice.
I love that so much. All right. Well, you guys know the name of the game around here is empowerment and education and getting this information out to you and into your hands. If you're interested in seeing these products, I was lucky enough that Laborie sent me a box of their products. So everything that we talked about today, plus a few more that are featured in the birth lounge. So if you're looking for truly unbiased, non-judgmental, evidence-based, just risk versus benefits, but very factual, evidence-based childbirth education. Check out the Birth Lounge, you guys. It's a membership. We also have an app, and you will be able to see not these tools in action, but I show you what they look like. We talk a little bit more about how you can have these conversations with your provider. That way, we take away some of that unknown. So when you see them, if you see them in your labor and delivery experience, you're not filled with fear. You actually say, hey, I know exactly what this is, and I'm super excited that I already have this education under my belt. I will see you guys in the next episode. Be sure to follow Laborie on social media, and you can find me at Tranquility by HeHe and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.